Welcome to the 5th Fracture Prevention Central webinar in a series of 6, Implementation of a Secondary Fracture Prevention Program in a Specialty Setting. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through support from Amgen Inc. and Eli Lilly and Company Inc. I'll now introduce you to David Lee, the Executive Director of the National Bone Health Alliance.
Thanks so much, and good afternoon to everyone. I'm really pleased to have you on the 5th in a series of 6 webinars sponsored by the National Bone Health Alliance Fracture Prevention Central Resource Center on fracture prevention programs. Just want to queue up a little bit for folks just to make sure everyone is familiar at a high level what a secondary fracture prevention / fracture liaison service program is, which is a proven coordinated preventive care model that operates under the supervision of bone health specialists, collaborates with the patient's primary care physician. The care of each patient is coordinated through a fracture liaison service coordinator, a nurse, PA, NP, other healthcare professional who ensures patients who fracture receive appropriate diagnosis, treatment, support, and follow-up. Patients are tracked via population registry. There are processes and timelines established for patient assessment and follow-up, and you can certainly see from soup to nuts how this program works, what the elements are through our Fracture Prevention Central resource, which is fracturepreventioncentral.org. FLS programs have been running for over 15 years in open and closed systems, both here in the U.S. Through the American Orthopedic Association on the Bone Program, Geisinger, who you'll hear from today, Kaiser Permanente internationally, in the UK, Canada, Australia, and many other countries. All of these programs have shown that you can reduce the number of costly and serious fractures by identifying these patients, given especially at those folks that have already fractured are the ones most likely to fracture again and that may have low bone mass and or osteoporosis. So this is just a little bit about Fracture Prevention Central. So we launched this resource center in March of 2013. In just about 6 months, over 1,600 people have registered to use the tools, access the tools. It really is a virtual place to share best practices, experiences, and tools. Certainly through this webinar series, I think we've been able to disseminate information and really hear from national and international experts on how to set up fracture liaison service programs, really the nuances of pulling together a program. As you can see here on this slide, the first 4 webinars that we have sponsored are available on demand. So you can log on to fracturepreventioncentral.org and get the links to directly be able to, not only hear the audio synced with the slides, but also get all of the slides and handouts that were provided on each. So we've had 4 so far, 2 to go, 1 today, and then another one that will be focused on primary care. We will have yet to be sponsored, but that'll happen either in November or early December. And then I also wanted to highlight one of our MBHA partner members, Own the Bone, actually is also sponsoring a webinar on November 21st on implementation of an FLS in rheumatology and orthopedics, and would encourage folks to participate in that. There's no charge to register. As you can see, you can visit ownthebone.org to be able to register for that webinar. So with that, just wanted to introduce today's speakers. So we'll have 2 speakers today. The first one is Dr. Meryl Leboff, Director of Skeletal Health and Osteoporosis Center and Bone Density Unit at Brigham and Women's Hospital in Boston. Her research is focused on understanding the causes of secondary osteoporosis, the effects of vitamin D on fractures and bone health outcomes, and the vitamin D and omega-3 fatty acid trial, and optimization of skeletal health across the life cycle from young adulthood to extreme old age. Dr. Leboff and her colleagues in the Department of Orthopedic Surgery identified a high prevalence of vitamin D deficiency among adults admitted to BWH with hip fractures, and thus developed the Brigham Fracture Intervention Team Initiative, which is what she'll be speaking about today. The objective of BFIT is to advance the care of hip fracture patients with implementation of an interdisciplinary fracture pathway, including modifications in the EHR to correct the vitamin D deficiency and evaluate and treat underlying osteoporosis. So really pleased to have her with us. Second person that I'll introduce now will be Dr. Thomas Olenjinsky. He is the co-director of the High Risk Osteoporosis Clinic at Geisinger Medical Center in Danville, Pennsylvania. He's co-director of the High Rock program and chairs the GHS Bone Mineral Density Committee, responsible for uniform DEXA reporting and risk stratification accuracy, and is also the lead densitometrist within Geisinger's mobile DEXA program. He's helped integrate an osteoporosis curriculum into Geisinger's Rheumatology Fellowship and also introduces residents and medical students to system-based and programmatic osteoporosis care. Importantly, he's one of the many champions in Geisinger of their osteoporosis program, and we're really pleased to have him here with us today to be able to talk about his the Geisinger work and the very mature program that they have at Geisinger. With that, I will conclude my introduction, but I will now hand it over to Dr. Leboff to get the formal presentation started. Thanks so much, and really pleased to have everyone with us.
This is Meryl Leboff. I'd like to thank David Lee and members of the National Bone Health Alliance Organizing Committee for inviting me to speak today. And today I'm going to review with you the Brigham Fracture Intervention Team Initiative, which is a hospital-based systems approach using the electronic health record to advance fracture care. The annual incidence of osteoporotic fractures is about 2 million a year in the United States, and 40% of women and 25% of men aged 50 years and older will develop an osteoporotic fracture. It's important to remember that while there are 300,000 hip fractures each year, 75 to 80% of fractures are actually non-hip fractures. And the osteoporotic fractures are extremely common, and as you can see, this compares to 500,000 heart attacks and 229,000 cases of breast cancer and 242,000 cases of prostate cancer. I want to start off with a case presentation. This is an 80-year-old woman who fell at home, and she was admitted with a femoral neck fracture. She had a spine fracture at age 65, shown here, and you can see she has a little bit of a kyphosis, and she's lost 4 inches in height. Most patients who sustain a hip fracture, in fact, actually half of patients who have a hip fracture will have a prior fracture. Her medications include hydrodiol, hydrochlorothiazide, and calcium 500 milligrams TID, which is actually more than what we currently are recommending using the Institute of Medicine recommendation of 1,200 milligrams daily. Her laboratory tests revealed eGFR of 48, and her calcium was slightly decreased at 8.6, and her 25-hydroxy vitamin D level was 13 nanograms per ml. So she has vitamin D deficiency, and this is a level that we've seen on average in some of the hip fractures that we've admitted to our hospital and studied. How would you evaluate and treat her? Well, fall prevention and balance training, evaluation for secondary causes of osteoporosis, a bone density test, treat her vitamin D deficiency, treat her osteoporosis, all of the above. Well, the answer is all of the above. And then the question is how to best implement this approach hospital-wide in our patients. Now, there's a vicious cycle of fractures, and fragility fractures increase in age in both men and women, as you can see here, the steep rise in hip fractures and spine fractures. And a fracture is a sign, it's a symptom of an underlying osteoporosis. Yet only 20% of patients with fragility fractures have a bone density test or are treated for their underlying osteoporosis. So this is a major gap in patient care nationally and internationally. The hip fracture is the most serious fracture. There's a high risk of a subsequent fracture, 2.5-fold increased risk for another fracture. 66% of patients do not regain their pre-fracture function, and there's a high mortality that is greater in men than women. Hip fractures are costly, around $26,000 a year for a hip fracture, and the costs of fractures in 2008 were estimated at $22 billion a year. These costs are rising with the rapid growth of the elderly population in the United States. Primary and secondary fracture prevention, improves patient care, and reduces healthcare costs. Today I'm going to review secondary prevention of hip fractures at our institution, and we have very active programs in primary prevention of fractures. As part of an NIH-sponsored study, looking at the mechanisms leading to hip fracture, we identified a very high prevalence of vitamin D deficiency in this group of patients. When we first looked at this, 77% of patients admitted with hip fractures had vitamin D levels under 20 nanograms per ml, which is in the deficient range, and the average was about 13 nanograms per ml. Only 10% had levels above 32 nanograms per ml. So we worked with the Baltimore Hip Study, J Magazine, and Bill Hawks, and we looked at the patients in the Baltimore Hip Study, and actually 89% of patients in the Baltimore Hip Study had vitamin D deficiency, and only 1% were sufficient. We've tracked this over time, and in 2010, when we did an audit of this, we found that 69% of our patients still have D levels under 32 nanograms per ml. So 31% had levels above that, and we still have patients with more severe vitamin D deficiency, with vitamin D deficiency less than 20 nanograms per ml in 40% of our patients. So we designed and implemented a multidisciplinary hospital-based approach to improve fracture care and also reverse the high prevalence of vitamin D insufficiency at Brigham and Women's Hospital. And so we translated our research findings into clinical care to try to advance fracture care at our institution. And this was a quality improvement initiative in which we use the electronic health records in our hip fracture patients. And we did this by working with champions in orthopedic research and surgery, and this is Dr. Julie Glowacki and Dr. Mitch Harris, who've worked with me on this project, and John Wright was also involved with this in the BFIT program. Some key components of the Brigham Fracture Intervention Team initiative are shown here. BFIT identifies patients through the Data Utility for Documentation and Education Clinical Database. This is called OrthoDude. It's in the Department of Orthopedic Surgery. And we track the fractures monthly on these patients, but when a patient's admitted to the hospital, we are able to identify them as a patient with a fracture, and this is applied actually to the inpatient and outpatient, but we're using this specifically for the inpatient hip fractures. And then we carry out intermittent auditing of our results. And we use the electronic health record to advance fracture care. And this is really important because patients are admitted at all hours of the day, and they're also on different services. They may be admitted in the emergency department, then they might be on medicine, or they may go to the Department of Orthopedic Surgery, and many of them will also go to the operating room. And so there are order sets that we needed to really reinforce this program in, and I'll show you those in subsequent slides. This is a systems-based approach in which physician leaders working on quality care initiative related to fracture work together to try to advance fracture care. And to bridge the gap in the hospital-based care and post-hospital fracture care, there are ongoing discussions that we have among physicians, physician leaders, residents, endocrine fellows and staff, orthopedic nursing, and computer information service team to help us with this. Now, it's important to remember that there are many secondary causes of osteoporosis, and we always try to identify a secondary cause, and especially a reversible process. So 80% or more of patients who are admitted with a hip fracture will have a secondary cause for their osteoporosis. Many of these are related to vitamin D insufficiency, renal insufficiency, or a number of endocrinologic causes such as hyperparathyroidism or hypogonadism. But then there are many gastrointestinal, rheumatologic disorders and invasive processes in the bone marrow, such as plasma cell disorders and multiple myeloma, that can be present in some of these patients. Now, shown here is a snapshot of of our discharge template, and showing the BFIT component in the discharge template. But by way of overview, this program includes order sets in an admission order set, a postoperative order set, and a discharge template, trying to really identify this patient as having a fracture and needs to be evaluated and treated for their osteoporosis at several phases during their hospitalization. So this is a multidisciplinary secondary fracture prevention collaboration between orthopedic surgery and endocrinology. And on the admission order set, we obtain a calcium, a 25-hydroxyvitamin D level, creatinine, and we give 50,000 units of vitamin D after the vitamin D level is drawn. And then endocrine is consulted to evaluate the patient for secondary causes of osteoporosis. And in the postoperative order set, where the patient is now post-surgical, there again, it's reinforced that it's important to have an osteoporosis evaluation and treatment for this fragility fracture, and they also have a surgical package at that point. The discharge template involves the outpatient care coordination, endocrine follow-up for osteoporosis treatment and bone density, and the bone density is really to monitor the therapy because a patient with a hip fracture has osteoporosis by definition according to the type of fracture. Assuming it wasn't with excessive trauma. And then we also include an exercise, balance training, and fall prevention with a physical therapist. And the fall prevention intervention we do for all patients with hip fractures because 90% of patients who have a hip fracture fall. And then we send reports to the primary care physician, both in the hospital discharged through the Department of Orthopedic Surgery, or in the Department of Medicine if the patient is admitted on a medical service, and then we also follow up with the referring physician and primary care physician in the outpatient setting. I wanted to show you several steps along the way as we develop this BFIT pathway. And in 2004, we developed the admission pathway, and we trained the orthopedic surgeons regarding hip fracture protocols and care. Again, we reviewed obtaining the lab tests that we thought were important in these patients. We started the hip fracture patients on a total of 1,200 milligrams of elemental calcium a day, and this is divided in 600 milligrams twice a day with some food, and 1,200 units of cholecalciferol, which is vitamin D3. 1,200 milligrams of calcium is what is recommended by the Institute of Medicine for postmenopausal women and men 71 years and older. We also include the ordering of the endocrine consult to correct the vitamin D deficiency. As I showed you, there was profound vitamin D deficiency in these patients, and which requires higher doses of vitamin D, and for secondary osteoporosis treatment and evaluation. We amended this protocol in 2005 to include a single dose of 50,000 units of vitamin D upon admission after the vitamin D level was obtained. And because in most of these patients we will start treatment as an outpatient, we also want to be certain that the vitamin D level is in a good range before we start treatment. We've looked at effectiveness of this approach by seeing whether the vitamin D level was obtained. In 2003, we implemented the postoperative order set so that we captured patients after they came out of the operating room with the order sets for the orthopedic surgeon at that time. And this was implemented in 2003 as a computer-assisted component of the discharge order set using electronic health record. And we thought it was really important to have this electronic health record component and a computer-assisted component so that the medical staff at all levels of patient care in the hospital can really understand how we were approaching these patients and trying to treat their underlying osteoporosis. And then the discharge template I reviewed with you, and that prompts the surgeon to prescribe calcium and vitamin D and a multivitamin on discharge, and then instructions for osteoporosis evaluation and treatment, including correction of the vitamin D deficiency and follow-up in endocrine. And the follow-up includes a bone density testing, physical therapy, exercise and balance training, and fall prevention with physical therapy. And we looked at the effectiveness of some of the pathways. This pathway is defined as treatment with calcium and vitamin D on discharge, to be sure that they were treated when they left before we finalized their evaluation for their osteoporosis and treatment. And as you can see here, since 2004, when we started doing audits of this program, we have steadily increased so that in 2010, about 80% of patients were having a vitamin D level drawn as part of this pathway, and about 80% were going out on calcium and vitamin D who were part of the Brigham Fracture Intervention Team pathway. So we have ongoing systems improvement, and we're bridging the hospital and care and the post-hospital care in the outpatient setting. So over time, more recently, we've modified our admission order set with information systems at Brigham and Women's Hospital, and again include Brigham Fracture Intervention Team instructions and evaluation and treatment for osteoporosis. And then the post-operative BFIT order set was also updated, and the discharge template was standardized throughout the hospital so that in the end of 2011 and 2012, we revised our discharge template, and this includes an endocrine follow-up for evaluation, bone density testing, and treatment. And on discharge, the ward clerk will call endocrine, or our fellows will set up an appointment in endocrine to ensure these patients are followed up there. We've also included some signage in the hospital, both inpatient and outpatient, to remind patients if they have had a fracture that they should be evaluated for their osteoporosis and treated for their osteoporosis. And as part of the discharge template, we have several pieces of patient education that we provide for them, both on the orthopedic surgery side and on the osteoporosis side. And each patient gets a Brigham and Women's Hospital pamphlet about fall prevention. But we also give them a brochure that I worked on called Healthy Bones for Life in the prevention, diagnosis, and treatment of osteoporosis. We tell the patient on their discharge template they get a sheet that they have had a fracture. They likely have osteoporosis, a condition in which their bones are brittle and weak, and that this increases their chances of having another fracture in the future, and that it's important for the patient to be seen and to get a bone density test and treatment within 1 month of being discharged from the hospital. Now, some of the osteoporosis quality metrics are shown here. Bone density test treatment after a hip fracture is generally we'll consider a once yearly zoledronic acid. It's a generic preparation is now available, and our pharmacy indicates it's about 1/3 the cost of the non-generic preparation. And we generally start zoledronic acid 2 to 12 weeks after a hip fracture. And this is an FDA-approved use following a hip fracture. And then oral bisphosphonates are also quite effective, and a generic alendronate is cost-effective for treatment of osteoporotic fractures. And then in some individuals, we'll consider teriparatide and glucocorticoid-induced osteoporosis, or denosumab. So shown here are the FDA-approved osteoporosis therapies. And the good news is that we have very effective therapies for treating osteoporosis, and that there are promising therapies on the horizon. And among those therapies, it's important to select a treatment that reduces spine, hip, and non-spine fractures. So among the bisphosphonates that decrease spine, hip, and non-spine fractures are alendronate, risedronate, and zoledronic acid. And as shown here are some of the side effects from these medications, but ibandronate does not reduce non-spine fractures and hip fractures, so this is not a drug that we would select in the setting of a patient that we're concerned about a hip fracture. Then there are other medications listed here, and among those that do decrease spine and non-spine fractures are teriparatide, the rank ligand inhibitor denosumab. So fortunately, we have effective treatments to reduce fractures, but only 20% of patients are being treated for their underlying fracture and osteoporosis. We have an unprecedented collective opportunity and a need to improve the quality of fracture care and reduce fractures and costs. The Surgeon General's report on bone health and osteoporosis in 2004 was a clarion call to improve bone health and reduce fracture risk. The World Health Organization FRAX tool in 2007 enabled us to identify patients with low bone mass who are at increased risk, have an absolute 10-year absolute risk for fracture over time, so that we can treat select patients at higher risk for fracture. The American Society of Bone and Mineral Research Task Force on Secondary Fracture Prevention 2012 underscored the need for implementation of effective secondary fracture prevention programs, and the National Osteoporosis Foundation Clinicians Guide in 2008 and 2013 have provided guidelines related to fracture care and identification of high-risk individuals and those with spine and non-spine fractures. And then the National Bone Health Alliance 2020 Vision call to action to work together to reduce fractures 20% by 2020. So thank you very much. I'd like to thank you for your attention and acknowledge the many people who've contributed to our Brigham Fracture Intervention Team initiative and bone health strategies. And then last slide. Now I'd like to introduce Dr. Thomas Onginski from Geisinger, who will talk to you about the program at Geisinger. Thank you.
Thank you, Dr. Leboff. And I'd like to thank everyone who's listening in and who will listen in on the archived webinar. I'd like to thank David Lee and the NBHA for affording me this opportunity. I consider this a privilege and really an opportunity to speak on behalf of a wonderful team at Geisinger who we think has been very dedicated to secondary prevention of fracture. Now, our health system is in central Pennsylvania. We have basically three main hubs. Our central hub is in Danville. We have an eastern hub in Wilkes-Barre-Scranton and a western hub in State College. Our health system is adapting to change, and over time, I think there'll be perhaps changes to our demographics. This slide is actually not accurate. We have, I think, over 1,000 employed physicians. Most importantly, we're connected by a shared electronic health record, EPIC, and we've been so connected since 2000. Really allows us to communicate effectively with each other. Now, our program actually began in 1996, really with a community intervention program, disease management guidelines, for 5 or 6 years, the use of a heel ultrasound program out in our primary care offices, and ultimately we evolved to a rather efficient bone density program. We've published rather effective and impressive results with our GEOP program from 2003 to 2008. In 2003, Dr. Newman and others at the bottom of the slide published a health savings paper really documenting $7.8 million saved to the Geisinger Health Plan. Since that time, we in rheumatology have been fortunate to have a mobile DEXA program, which I'll talk to you about. We have integrated vertebral fracture assessment. We've tried to really uniform and systematize our DEXA interpretation as best as possible, and really tried to really assume the mantra, make it easier for our busy primary care physicians to do the right thing. Over the same period of time, we've been clearly aware of the care gaps that Dr. Leboff has nicely presented in her talk. And because of that, we kind of evolved into our FLS program. Now, this is an example of an increase in bisphosphonate use over the time period of our publication in 2003. a reduction in hip fracture rate that continues beyond the years in the publication, and most importantly, cost savings. When it comes to care gaps, the Gia Gregorio paper is, to me, the best gap paper because it really looks at over 200 publications where something sentinel occurred, namely a fracture, and the analysis was something done? Well, the bottom line was rarely was something done. And this wasn't really a commentary on orthopedics. It was a commentary on primary care and subspecialty care as well. In our health system, we really focus on 4 gaps. At-risk patients not tested, tested patients not accurately risk assessed, and when it comes to our FLS service, we really focus on high-risk patients not treated and treated patients not adherent. Now we're going to talk about bone density testing rather briefly, but we basically, in our uniform DEXA interpretation, focus on 4 groups. We basically feel that 4 groups of patients stratified should in fact be treated, and I think the NOF and really the IOF would be in accord with this. Clearly, the hip or spine fragility fractured patient has the clinical diagnosis of osteoporosis. A DEXA is typically going to be done to monitor their treatment response. Those postmenopausal women or men over 50 with a T-score of -2.5 or worse will be stratified as high risk, and the recommendation will be to treat. Importantly, group 3, those older patients with low bone density who now have weighted clinical risks that can be stratified through the FRAX tool, are really a very important group. And I'm going to point out later that that's a very important group in patients in the hospital with non-vertebral fractures where that FRAX tool is going to be necessary to stratify. And finally, the 4th group, those patients who meet a ACR GOP 2010 treatment threshold. Now, I'm proud to say that our primary care physicians really form the base of our system-based care, and they provide excellent osteoporosis care. What we've really done with our program is use that base and try to enhance and try to get to the gaps that we know exist. So in an analysis between 2004 and 2005, we looked at approximately almost 400 DEXAs that were high risk, and we knew patients were drug naive. Within 90 days of one of our DEXA reports, 72% of patients were placed on treatment. Now, Dr. Leboff indicated that only about 20 to 25% of patients with osteoporosis today are treated. So while we're very satisfied with this, we really want this measure to be better. We believe this is occurring because our primary care physicians have bought in to our DEXA reporting, and our mobile DEXA vans go right to our primary care offices. They consider that a part of their practice. We try to give them excellent service, and importantly, we try to make it easy for them to do the right thing. And if they have a question, they can easily contact us through our health record. Now, this is an example of one of our mobile DEXA vans. We have 7 fixed sites offering bone density testing and 2 vans. The 2 vans are really the Department of Rheumatology. We take great pride in this. Our team, including our drivers, our technologists, our support staff, are simply superb, and we're very proud of this. This, to me, is the glue of our connection with our primary care physicians. Now, we believe in quality control. So we do meet amongst all readers. We have a standard policy and procedure manual, and we try to do the right thing. Now, there is a little bit of variation in our system. I wouldn't be honest to say that we're completely uniform. Around 2007, our radiology group diverged from clinical reporting and really started to report in what we will call a results-only fashion. We looked at the difference in what our primary care physicians did when they received a report either through consultative reporting versus results only. And clearly, consultative reporting was followed in 72% of cases in a high-risk patient needing treatment with treatment, as opposed to 50% in the results-only reporting. Now, obviously, we have to try to improve on this in our system. So really the infrastructure is our primary care base and what we've done up until 2007, 2008. So what are we doing now? Well, I don't think we're necessarily trying to climb a mountain, but we are trying to indicate in our efforts that buy into a fracture liaison service post-fracture, integrating that with an existing outpatient pathway and excellent primary care in our system seems to be the way to go. And I'd like to present that now. So basically, we again wanted to enhance what we thought was existing excellent primary care. We developed initially an outpatient high-rock clinic primarily to add treatment options that were difficult to administer in our primary care settings and also avail ourselves to those high-risk patients or patients otherwise who primary care physicians and other providers needed help with. Once we designed that, we turned to an inpatient program, really integrated and married the two, made this available throughout our system, and really what we've done since that time is learned valuable lessons, adapted, and we're trying to continually improve to do a better job. So we initially met in the summer of 2007. Gwyn Maloney Saxon is our clinical nurse specialist co-manager, along with myself, Dr. Newman, and the rest of our rheumatology staff and supporting staff. We developed a mission statement, established goals. One of the goals was really to risk stratify anyone with fracture. It's real important. Risk stratify doesn't always mean we're seeing a fracture that we would de novo treat because it's hip or spine fragility. Just similar to Dr. Leboff's program, we wanted to capitalize on our electronic health record and develop easy-to-use documentation tools that allowed us to effectively communicate. We paid particular attention to flow. Marketing and trying to brand High Rock has been very successful. On the outpatient side, we started with 2 primary care offices as pilots, and after a month of piloting, we really started the program, integrated it throughout, and then we added the critical inpatient fracture component. Our mission was to enhance the care of high rock patients or high-risk patients across our system. We anticipated patients who needed to be treated who might be GI intolerant, might have had fractures despite therapy, might have had trouble responding, poor BMD response, complicated GI patients with absorption issues, chronic steroid users, or other patients who simply needed help and a primary care physician or mid-level provider would ask us to help in their care. Throughout this journey, we established partnerships with departments where we really tried to simply make it easy for them to get into our program, not necessarily needing to be a high-risk patient. Particular partnerships involved neurology, dermatology, pulmonary medicine, and some other services and service lines. And over time, it's clear that the long-term treatment question, the almost unanswerable question of drug holiday, how long to treat, has become a very important part of our program. So, again, we built the team. We established a mission statement and goals, designed the program predominantly looking at electronic documentation, tools to efficiently utilize our strengths, communication, and again, once we had the outpatient arm that supplemented our primary care base, we then added the inpatient component. Again, marketing, implementation, and measurements. So we thought the outpatient program would be unique because we would use pre-visit information gathering to increase efficiency. For several years, we pre-arranged a 25-hydroxyvitamin D level, calcium, and creatinine. We had DEXA to increase the pre-visit huddling and to make it easier. We wanted to definitely have a treatment decision at the conclusion of the visit, and we really designed an efficient pre-auth process very similar to what we use in our biologic pre-auth process for drugs such as intravenous bisphosphonates, teriparatide, and denosumab. obviously education and really getting the patient to buy into why we're trying to do this, the importance of osteoporosis and the risk of complications, and really developed a plan to assess compliance and adherence and effective communication. Again, we chose 2 primary care sites. We piloted those. We tried to keep patient convenience at the forefront. Our primary care sites actually suggested that we put in a HYROC referral reminder within our DEXA templates. So our reports have this. Our primary care docs don't necessarily. We didn't want to see every patient who was high risk because that clearly would have overwhelmed us, but our docs can selectively determine whether they need our help. And obviously input from scheduling and clinical support staff. 9 months into the program, it was clear we needed someone behind the scenes who we call our HYROC data coordinator, Karen Makowitz. She's been absolutely essential to the success of our program. Again, using the electronic record for documentation and efficiency, standardized electronic referrals, consultation clinic notes, follow-up clinic notes, ordering sets for DEXA, laboratory studies, secondary evaluation, treatment, and follow-up, and patient education handouts on our program, osteoporosis, its importance, medications, calcium, vitamin D, exercise, and fall risk. Our flow involved 2 clinical nurse specialists and our rheumatology fellows who would have patients scheduled for 45 minutes to 1 hour, and our attending staff would be scheduled to see those patients in the last 15 minutes of that visit, and using staggering start times. If I was in clinic, I could collaborate in the care of 4 new patients every hour. This has really turned out to be a very efficient model, and I will tell you that the day before I look at what I'm going to see, we often huddle before we even start to see patients, and this helps us be more efficient. We do this on Tuesday and Thursday mornings. Once we had our clinic established, we clearly needed return visits, and we typically do that on Tuesday and Thursday afternoons, but we also do that on Mondays and Fridays. So spring of 2008 was the first site. Second site added 2 weeks later. The HYROC referral language and tools were put into our preferred order list in our Epic Health record, and marketing efforts continued. We integrated this in our eastern region and western region, and in addition, some of our rheumatology staff go to outreach clinics, so we actually have on-site HYROC at 11 other practice settings. Now, schematically, on the right, we typically expect a patient who needs to be treated, but not necessarily. So we have a high-risk DEXA, a consult's placed, we schedule the patient. Even before the day of consult, we begin our data gathering. Our nurse specialist or fellow sees the patient. We assess vitamin D. We review the case, collaborate, and come up with a treatment decision collectively. We initiate a pre-auth after that decision if it's needed. We begin treatment, and if it's an oral bisphosphonate, we initiate an oral bisphosphonate. If we choose an IV bisphosphonate, we need a pre-auth process, and if we choose teriparatide, we're likely going to need a pre-auth process. Obviously, when denosumab became available, this was integrated within our treatment regimen. For patients on an oral bisphosphonate or patients who are treated with raloxifene or teriparatide, we call it 3 months to assess, and this is where our HYROC data coordinator has come to help greatly. For those patients treated parenterally, we follow them up at 1 year. We follow calcium and vitamin D, and at 1 year, we see how the patients are doing. We make a yearly decision on what to do. Some patients are returned back to primary care physician, but for many patients, we continue to follow. And as I said with the long-term therapy question, it's that question and ongoing requests to continue to own that question has shown that we're seeing more and more patients back on a yearly basis. Again, we have this available at 11 sites in our system, and we try to get to adherence compliance and yearly follow-up. Now, the inpatient fracture component involved stakeholders such as general internists, hospitalists, orthopedists, nurse managers, rheumatology, ER, our trauma service. We met, we discussed, and we all achieved a consensus on the importance of the FLS concept. Admitting services place auto consultations within their order sets termed inpatient hierarch. We in rheumatology receive that consult and we see the patient. We see patients over the age of 50 admitted with a fragility fracture of the spine, hip, or other. So initially this was spine and hip primarily, but it's really evolved to any fracture in someone over the age of 50, excluding the hands, feet, or the face. So we've become very respectful of non-vertebral fractures. So again, there's a standard available checkbox on all admission order sets for general medicine, our hospitalist services and orthopedics. They assisted in decisions about where in the record and how they would utilize these charting tools. We in our department received the consult. Our fellow or a general medicine resident will see the patient, discuss with staff, and similar to outpatient, health EHR consult notes and other orders are utilized, as well as communication pathways. So we piloted this program in November of 2008 here in Danville. It officially began in December. Our eastern region began a year later, and our western region began about another year after that. So we now have this in all three sites. So again, hospital care is attended to by GIM, ortho, or trauma. We get 25-hydroxy-D, calcium, and creatinine. And again, similar to Dr. Leboff's service, we initially start the patient on supplemental calcium, vitamin D, assess their level, and make determination thereafter. After the consult's completed, a telephone counter is sent to our data coordinator. We specify location of fracture, the recommended treatment, whether we need a DEXA, and patient is entered into our database. Thereafter, we initially thought 4 to 6 weeks post-fracture and post-discharge would be key. It really turns out that 6 to 8 weeks is better when we look at how easy it is to find the patient, whether they've likely completed their rehab, etc. And what we finally try to do is close the loop of care. We schedule a follow-up. In follow-up, the patient seen by one of our nurse specialists and staff. If they have a hip or spine fracture, risk stratification is already done. If we already know they're high risk and they've had another fracture, we know we have to assess whether to change treatment or not. For others, DEXA will be needed, and the FRAX calculation may be pivotal to their risk assessment. And we proceed similar to the outpatient pathway. If a patient refuses or is lost to follow-up, we send a standard letter with individual treatment recommendations, and we send it to the primary care physician. And one of the things about our system, we have primary care physicians who are Geisinger employed, part of us, and we have many primary care physicians not employed by Geisinger who are impaneled by our health plan or who are in the community and our patients see them. And there's a different communication pathway, and there are different barriers in both of those assessments. So in summary, on the right, a low-energy fracture in someone after the age of 50, that patient is admitted, and that service, typically general medicine or orthopedics, places an auto consult using a order set in Epic. We do that hierarch consult. It gets placed, the data gets placed in a task management database. We do a secondary causal workup beyond, if indicated. We start on calcium and D, assess vitamin D, and try to get the patient into our outpatient pathway. At 6 weeks, our coordinator tries to call and arrange follow-up. If they're able to come, we schedule, assess, and proceed just like in our outpatient arm. If the patient refuses in the middle, we can't, for whatever reason, we can't get that patient in follow-up, we try to send that a communication to the primary care physician and make recommendations, and at least we close that loop. Our volume since inception, we've seen new outpatients over 3,000. This is all of our sites. We've seen over 2,500 return patients. There's a new data, a hospital discharge follow-up. That's a relatively new designation. We just want to see how many hospital discharge we're truly seeing. So 326 doesn't mean we've only seen 326. We've just coded or classified 326. As far as the inpatient side, we've seen 1,572 consults. I think this is through September of this year. Initial results of the first 200 outpatients on the left, we started treatment in 80% of patients, and assured adherence at 3 months was 98%. Importantly, on the right, looking at our first 100 inpatient HYROCs, there is a major disconnect between treatment started if they're followed in our centralized HYROC program, 83%, versus primary care treatment goes down to 25%. If you look at this currently, we're basically at about 70 to 75% through HYROC and about 30% through primary care. Now, a couple other things we've learned. Number one, we've learned to look at x-rays. We've learned to be very careful to look at where a fracture in the femur occurs. We've learned to look at other things in the record that might signal that patients have had other fractures. We appreciate that if a patient is admitted with a hip fracture, 40 to 50% of them have had a fracture at some other point in time, often not followed up by a workup and treatment. Again, the other fracture is the fracture where we're going to need a DEXA to risk stratify to use FRAX or T-score. We often see patients in the hospital who we have seen before and have fallen off treatment. We readdress the need for treatment. We may see patients who have been lost to follow-up, and we can reestablish care. So every time we get to see a patient in the hospital is a chance to do the right thing and to assure long-term follow-up. Our outcomes, we see about 50 to 55%. So 50 to 55% of people we see in the hospital actually choose for various reasons to be followed. So 50% or 45% choose not to follow up with us. They are returned to either their Geisinger primary care or non-Geisinger primary care physician. Obviously, the likelihood of prescription treatment is higher in our centralized program versus in the return to primary care. We've improved mean vitamin D levels from 27 at baseline to 35, which is an important consideration. The one other thing not shown is we've really done this and basically, if I may say, stayed budget neutral. This has really not hurt us, but it's required a lot of work, and it's, again, a testimony to our complete team. Our hip fracture rate in the health plan continues to fall. And again, when I look at this, it simply encourages me to continue trying to do what we're doing in a better way. And finally, this is just a summary of our program. We obviously believe in groups of patients at high risk, at top in yellow. I wish I had the primary care physician in the center here and high risk out here, but I don't. Obviously, we have the inpatient and outpatient arm where we can assess patients with fracture. We can follow patients where primary care physicians want us to follow them. And again, we've integrated this throughout our system. The lessons we learned, pre-program planning is essential. A coordinator, including our data coordinator behind the scenes, Karen, essential. Our database is essential. Really, outpatient HYROC has become a source of really long-term consultations. And inpatient HYROC essentially sees all fractures except those of the face, hands, and feet in patients over 50 who are admitted. The biggest challenge is getting patients to follow up. Post-fracture care remains challenging. In conclusion, I would acknowledge just great people. Eric Newman, my director, our director, Gwen Maloney-Saxon, superb clinician, Cindy Matsko, the nicest, most dedicated nurse specialist you could find, Karen, our data coordinator, and all of our staff. And finally, I would just remind everyone that in 2013, a fracture liaison service, unfortunately, is not the standard of medical care. So my hope with the work of NBHA, the National Osteoporosis Foundation, and others would be that FLS really becomes over time the standard of care so that the great work that the other programs we've heard about can continue and disseminate throughout our country. So with that, I thank you for the opportunity, and we'll now have time for questions.
Thank you very much. To ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. If you wish to ask a question live via the phone, press star 1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember, if you have your phone on mute, take it off mute when you are selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. And to ask a question live, press star 1 on your telephone keypad. And there are no phone questions at this time, so I'll turn the program back to David.
Great. So maybe while folks are thinking about questions, I know we've got about 5 minutes left. I guess just a question for the two speakers, because obviously you all have been running your versions of a fracture liaison service for a while. Maybe just talk about the one or two kind of turning points from discussing the setup of your program to to me those decision points where you're really off and running and you had the institutional support that you needed. I think that'd be interesting for people to hear, especially the folks that are just starting to develop a program now, to certainly learn from your experience and expertise.
I'll let Dr. Leboff take that first.
Yes. So I think there's some key components to organizing this, and I think first of all, I think you need a committed group of champions within your hospital to help you orchestrate this interdisciplinary program. And I think the ultimate goal is both the secondary prevention of fractures and the primary prevention of fractures. And so just working with the administration if necessary, or with the information systems group is important. Radiology for identification of those non-hip fractures, such as spine fractures, is critically important. And I think we're striving to really identify the fractures since about two-thirds are not clinically evident. The spine fractures that may be identified in a hospital setting and have not been really identified as an osteoporotic fracture that may be picked up on an X-ray, for instance, or a CAT scan. And I think it's just the key components are working together with the different disciplines within your hospital and the many individuals who really provide excellence in patient care, the nurses and the ancillary staff, as well as the physician and residents, to implement this type of program.
I would agree with that, and I would say just what I've written down here. You have to have a will to do this. We're somewhat different because this whole program that we got involved in really allowed us to be at the forefront of any changes in systematic osteoporosis care. And I think, I believe our administration looks at our rheumatology department and what we've done over the years and says, okay, they're really motivated, they can do this. So we've been given really an unbelievable opportunity. The mobile DEXA program to me and the interfacing with primary care to me is the glue. I remind myself every day that despite reduction in DEXA reimbursement, I interpret DEXA every day, and I communicate this to a great group of primary care physicians. We have many champions. I mean, Eric Newman is a great champion. Bill Ayub in the West is a great champion. And in the East, I'll signal out Dave Puglisi and Brian Delvecchio and Maria Butterwick. Here in Danville, Gwyn Maloney-Saxon, Cynthia Matsko, our coordinators, and our staff. And basically, the other thing is, in getting back to what things Rick Dell said, you really have to, you need data, you need to look at it. When we initially looked at our follow-up rate, we kind of looked at that disappointingly. But after a while, I said, we're following over 50% of people who we never saw in the hospital before who fractured. We're doing this in our eastern and western regions. We're probably going to add more sites, I believe, and we have an outpatient arm, and we have great primary care. So we have to do better, but we have rather some unique, really privileges here, and I'm just fortunate, and I would encourage anyone to look at what you can do and try to do it your way to the best of your ability.
Great. And I know we're right at time, but have a few quick questions I think we can squeeze in. So the first question was from Kathy Williams, the Kaiser Permanente Healthy Bones Program. A question for Dr. Leboff. Do you have a formal coordinator component to your program?
At this time, we don't have a formal program coordinator to our program.
Okay, great. Thank you. And then just one question I see that came through just related to the handouts. So about a week from now or so is usually when we're able to put the on-demand version of the webinar up, and that will actually include the slides from today's talks. Let me see. Just maybe one last one. And I guess when I ask the speakers if they have an opportunity to stay over a couple of minutes. But this is a question from Tim Manzoni from Christiana Care Health System. How do you capture the other fractures who don't get admitted from emergency department records, et cetera? How exactly do you capture those folks?
Well, I'll tell you how we try to do that. Number one, coding and your electronic health record is important. We would like to get to a point of actually coding by high risk rather than osteoporosis. Our orthopedists are excellent at getting patients to us. Our primary care physicians understand we really believe in secondary prevention of fracture. There's data in the record that you have to go through, but I think we're all aware of gaps, and I think every system or a community hospital or a network of physicians can really say, okay, we can address this way, we can address this way. We're actually trying to really use identification of certain language in our electronic health record to identify such patients looking through our record. So those are just some thoughts, and I appreciate the question.
Gotcha. Thank you. And maybe we'll take one last question, and this is back to you, Dr. Olenginsky. Do you use the Rheumatology Epic Overlay PACER as a part of the HiRock EHR communications?
Wow. Dr. Newman will love this. We don't do it now, but we're going to have a new upgrade, and it's very likely that we'll do that on the outpatient side. And really, PACER has so many attributes. So we're excited about this new version, and we're likely to, but right now we don't. But it's pretty easy with Epic and the electronic tools, really similar to how Dr. Leboff and their group uses the electronic record. But in the future, I think we're going to be using it.
Great. Any final comments from the speakers? I know we're a little bit over time, but wanted to give a chance for any last comments.
I thank you for inviting me to talk today, and I just think it's critically important for everyone to try to bridge this gap in care that we have in the United States and worldwide to really make sure that every fragility fracture is evaluated and treated for the osteoporosis that underlies most of these cases and patients, and also primary prevention is critically important. So I think it's a big charge, but I think certainly we can do this nationally to reduce the number of fractures by 2020.
I would agree with that. I would also just put in a plug for all of the other speakers. I've accessed via the archive webinars those presentations. They're excellent. The MBHA website is excellent, and I think we have to learn and share with others and kind of find our own way. But I agree. By 2020, I would hope to think that the FLS is everywhere, and we're doing great work. So I appreciate the opportunity, and thank you again.
Thanks to you both, and that's certainly our goal. You know, we have done the back of the envelope calculation, and we're looking at needing about 1,000 of these FLS programs in place to achieve the 2020 vision. Probably have somewhere between 150 and 200 in place right now, so obviously have a long ways to go. So we really see the folks on the call and participating in Fracture Prevention Central as the army that's going to help us achieve that vision. So really appreciate everyone's participation, questions. If you have any follow-ups, certainly feel free to connect with me directly, and I can get you in touch with today's faculty. And have a great day.
Thank you.